Welcome everybody to our ISSM webinar on Oncosexology in Sub-Saharan Africa. My name is Estela Citrin. I am the member of the Education Committee on ISSM. I would like firstly to welcome everybody from different countries and say that, as you know, in ISSM, we believe that every human being has the right to a healthy and satisfying sexual life. And in order to do so, we think that our mission is to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publications, research findings, online and in-person opportunities for knowledge exchange worldwide. We invite you to visit our journals, the Journal of Sexual Medicine Open Access, Sexual Medicine Reviews, and the Video Journal of Sexual Medicine. Saying so, I would like to first introduce and welcome our moderator for this webinar, Philip Odio. He is currently working as country lead for Africa Chapter, US non-based nonprofit organization. His passion for psycho-oncology began 15 years ago. Besides having a master's degree in counseling psychology, he is currently studying for a research doctorate degree at Erasmus University in Netherlands. Philip was selected for a clinical leadership and training at Memorial Sloan Kettering Center in New York, where he was mentored by Dr. Jimmy Holland under the Union for International Cancer Control Fellowship in 2014. He's also a fellow for the Association of Union for International Cancer Control Fellows and was awarded Naomi Stern's Fellow in 2018 for his role in development psychosocial oncology in Kenya. He was elected in 2019 to 21 as a director representative in Africa International Psycho-Oncology Organization. He's currently the Secretary for Prostate Cancer Support Association in Kenya and Vice Chair of the Kenyan Network for Cancer Organization. He's also a committed member representing developed countries at the International Society for Sexual Medicine, ISSM, and the Vice President of Association for Psycho-Oncology Society in Africa. Saying so, with this very impressive CV, I will let you, Philip, the floor is yours.
Thank you so much, Estella. Good morning, good afternoon, good evening from where you're logging in from. Like Estella said, my name is Philip Odio, and I will be moderating today's session. And it's going to be an interesting live session. So we're encouraging you, if you have questions, we have the question and answer box. Just share your questions on the box, on the chat, so that we can be able to read the questions. We'll answer them later. And then kindly, everyone who is joining, kindly mute yourself. We know the common etiquettes for virtual meetings. Mute yourself. If you have a camera, just make sure that it's off. And we are going to have a wonderful session. So our first speaker for today is somebody that I respect. We worked with very well in Kenya, Professor Joachim Osur. Joachim is one of the few medical sexologists we have in Kenya. He's a medical practitioner and he's also a professor of sexual and reproductive health, as well as the vice chancellor of AMREF International University. He is a member of the American College of Sexologists and a fellow of the Multidisciplinary Joint Committee of Sexual Medicine as designated by the European Union of Medical Specialists. He is also a lecturer and a researcher, and as well as service provider in sexual medicine in Nairobi, Kenya. He is also a member of the Education as well as Social and Cultural Ethics Committee of the ISSM. I would like to say that Prof. Joachim Osuri is a Kenyan, and he writes a lot of amazing articles on sexual issues in Kenya. Welcome, Prof.
Thank you. Thank you very much. And a very great pleasure to be part of this webinar today, where I'm going to be talking about cancer and sexuality in a cultural and religious context. And I know I'm African, but every community has a culture. And so disease happens in a cultural context, in a social context, and this varies from place to place. So we can start with the slides. As you've heard, I'm a member of these committees of ISSM. We go. So I'm going to be basically looking at three things. The cultural role of sex and what happens when cancer happens, how people adapt, the patient and the family, how they adapt to the new situation when cancer strikes, and how we can apply some of this knowledge in practice, some of the takeaway messages that we'll be talking about. So as I start, it is very important, this slide. If you read literature on sexuality, culture, and cancer, you get a lot of negativity around culture and sexuality and cancer. For some reason, researchers and commentators and clinicians, when it comes to the issue of culture and how it is affecting disease, people are very negative. And I think this is a deficit perspective because we may not really understand a lot about people's culture. And so because we don't, we tend to look at it negatively. And when we do that, then we obscure what is meaningful to a patient, because a patient is coming from a cultural and a social setting. So when you dismiss who they are and where they are coming from, then they don't get meaning from the treatment we give. But it can also limit provision of optimal cancer care, because you cannot provide comprehensive care when you do not consider the context of the patient. So let's continue. Next. So recently, as you've heard, I do run a clinic on sexual medicine. And recently I had a very interesting scenario where a gentleman who has cancer of the colon, on treatment with radiotherapy. Of course, radiotherapy of the pelvic area means that there will be some damage to the testicles and all that, and production of testosterone may go down. And so you find sexual issues arising. At the same time, of course, the disease basically wears out your body, and you find that people lack energy to be sexual. And because of the stressful nature, people always think of death when they think of cancer. Because of all that stress, sex just doesn't happen. But this couple came and the wife was very agitated. And she said, the cancer is in your colon, not genitals. Can you give me a better reason why you cannot have sex? Because it had been over 6 months and they had not had sex. Now, one may think that this is a very insensitive wife, but it is because of the cultural context that these people are coming from. In my following slides, you will see why it becomes so difficult to survive as a human being in a social context when sex cannot happen and when it is because of cancer or whatever reason. So next slide. When you look at many cultures in Africa, sex is not just for pleasure. Sex has many other meanings, and there are many other reasons why people have sex. I come from a community called the Luo, those who know Barack Obama. That is where his ancestral people come from. And in this community, at the beginning of the rainy season, the head of the family has sex with the first wife because they are polygamous traditionally. The next day, they plant the first seed. And this is the surest way to get a bumper harvest. In other words, they believe that if you don't carry out this ritual that families do before they plant seeds for the season, then you cannot have a good harvest. And so food security becomes an issue. And so you see a very direct linkage between the role of sex in food production and food security to this community. Next. If you cross the border from Kenya, you go to Uganda, you get the Baganda people. These people believed quite a bit in the, should I say virginity, but just the first act of sex. The first act of sex where blood is shed, they believed there is something so unique about it, so supernatural about it, that a community has to celebrate the first time sex happens. So the bride's aunt, when marriage was happening, would escort this newlywed girl or woman to the new home and would be waiting for the first sex to happen. And in the morning, they would check if there was blood from the breaking of virginity, and they would carry those beddings back to where the girl came from. And there would be a whole celebration in the village and in the community because sex had happened for the first time in this family. Next. When you go down to the Southern Africa, the Shona people, they say lovemaking is sacred and ancestors are invited to participate. And a recital of praise poetry known as Nhetembo Zemugunza happens during sex, in which the husband and wife praise and encourage and thank each other together with their ancestors in the act. It is said that sex is so dramatic in this context that it is done away from the sight and ears of children. And so you find that the bedroom for the father and mother was always away from the children because of this very sacred connection which happens during sex between the living and the dead. And this has serious meaning in life to this community. Next. And so when cancer strikes, and for all those reasons that you know, sex is not possible or is not happening the usual way, for many communities, medical explanations are not adequate because there is a disruption to a whole lifestyle. It's a disruption to the meaning of life. It's a disruption to connection with the gods, to food security, and to everything that people already know and live. And so it becomes something new. It's a new experience that most communities are unable to cope with. Inability to have sex basically disrupts all aspects of social life. And so people want to have a cultural explanation. Why did this happen to me? Who am I now? And so on. And so you start to have beliefs on origins of illness that are not really medical, because the disruption between communicating with the ancestors and the gods, the disruption in food production, the disruption in celebrations in communities is gone. And so when the medical people try to explain that this is cancer, and if it is cervical cancer, it is caused by some virus, those explanations may not fully explain to the person what they have found themselves in. If you go to Ethiopia, the Konso people of Ethiopia, Their worldview as it relates to health, illness, and healing is closely linked to their day-to-day lives. And older people believe that illnesses are caused by a range of supernatural forces, including the wrath of God or local gods, or what they call Orita, which is spirit possessions, and Karaita, which is ancestral spirits. And they use cultural prescribed treatments for diseases that we may know medically. And so there is a lot more to disease, to cancer, to disruption in sexuality beyond just what we know medically. Let's continue. Sometimes this leads to some identity crisis. If you get cancer, if someone gets cancer and there is all this disruption that has happened, the person, they think they are a lover, companion with social obligations, which includes satisfying some cultural obligations, which are sexual and all that. That is whom they know themselves as. But then they are sick and the disease makes them realize that they have an imperfect and disease-ravaged body, which is fighting to live, where sex may not be a priority. Next slide. And so this identity crisis can lead to what we call social identity threats, which is a situation situationally triggered concern that one is at risk of being stigmatized, because you start to realize that I'm no longer culturally appropriate, I'm no longer socially appropriate, I'm different from a normal person. Social identity threat stems from awareness of the cultural representations that associate a self-relevant social identity with undesirable characteristics. So if I have something that socially is considered undesirable, and I'm aware of that, then there is a high risk of social identity threat. There are situational cues that bring self-relevant cultural biases to mind. For example, the belief that a cancer-devastated body is not sexual. Social identity threat can lead to many psychological and physical processes that have detrimental consequences for health. And so as we provide medical care, nursing care using conventional medicine, if we don't think beyond some of these, then outcomes may not be good. Now, when people go through this social identity crisis and all the other things that they are going through because they have cancer, they start to ask hard questions, which medical people cannot answer. And so socially, you find they start to pray more than before. They consult with family and friends on what the future is for them. They start consulting divine or traditional healers because they don't just trust the doctor anymore. If anything, doctors are mortals and they're limited in what they can do. And so they're looking for more explanations for their circumstances. Next. Now, people who provide services, both sexual medicine and cancer-related services, should be aware that this scenario, this situation, this context that patients find themselves in can have both positive and negative consequences. Positive in the sense that special care by family members can be enhanced. People pay more attention. They realize that there is a big problem that it's not just affecting the person, but the whole family and all the dynamics of the family and relationships and all that go beyond the human understanding. They can be put on special diets. They can have herbal remedies. Some of these work, some don't work. Some actually interact with the medicines that are given in hospitals. Psychological care can be better. Religious intervention can be more. And the sick role, the behavior expected of the sick person can be such that it is more accepting to care from all sources. But on the negative side, this experience can make people not adhere to medical care, because especially if medical people do not understand the wider context of what this person is going through. If they just want to give chemo or radio and not talk about the other aspects of care, sometimes patients may not adhere to treatment. But also because of increased attention by family members and everyone, there is always disruption in privacy. People may not sleep in the same rooms where they have been sleeping, and so sex may not be possible. There is disillusionment. Sometimes there is stigma, especially when the disease is prolonged. And sometimes because of the social disruption and the cultural disruption, the patient may be blamed for having brought all the bad things to the family. Next. So some take-home messages. There is more to sex than just pleasure when you think of a cultural and social context where a patient is coming from. Cancer and its treatment disrupt sociocultural obligations and roles of the sexual person, and can lead to social identity threat, which compromises well-being. It is very important that service providers work with communities to align sociocultural and religious expectations in the face of cancer to the treatments that we give in hospitals. We should endeavor to understand cultural expectations, and these are really diverse. So depending on where you're working from, you should know that people are coming from a context, and it is very important that health workers understand that context and give treatment within that context and discuss the other expectations beyond just chemo, radio, and even surgery. We need to work closely with cultural leaders as part of care to improve adherence to treatment. This, of course, includes religious people as well. And there is need for more research and adaptation of indigenous practices that may improve treatment of cancer. I think we need to understand that there is something good culturally that can be helpful, and we need to know what that is and see how to apply it. And I think that is my last slide. Thank you very much.
Thank you very much, Professor Osur. We really appreciate. So please use the chat to put your questions, and we'll be answering them at the end of the call. Our next speaker, Professor Daniela Whitman, will be talking about history of education on sexual health and medicine in Sub-Saharan Africa. Dr. Whitman is a clinical associate professor emerita in the University of Michigan, Department of Urology. She is a psychotherapist, educator, and researcher. She was lead faculty in developing Brandon prostate cancer survivorship program at the University of Michigan. She is an ASSET certified sex therapist and sex therapy supervisor. She is a former associate editor of the Journal of Sexual Medicine. She has also published research, reviewed opinion articles and chapters on sexual issues in cancer and urological diseases. She is also the lead author of international guidelines for sexual health care in prostate cancer. And her research focuses on using mixed methods to develop and test interventions that support couples' sexual recovery after prostate cancer treatment. Karibu, welcome, Professor Whitman.
Hello, everybody. It's such a pleasure to be a part of this panel and to be able to talk about this really important subject. Can you please move the slide? Here are my disclosures, and we can move on. So I'm going to continue with context because Professor Osur really provided beautiful context for explaining how we went on to develop basically now a training program on oncosexuality in Sub-Saharan Africa, giving all of us the understanding that this is something that is not just a sort of sexual health, sexual medicine expertise issue, educating people, that we really have to consider where people live, where they come from, what their views are on sexuality, and that varies across the globe. So my context is going to be more cancer focused. Just in this figure, you see the incidence and mortality in the most common cancers in Sub-Saharan Africa, and you can see that prostate cancer in men and cervical cancer and breast cancer in women are the most prevalent cancers, and that in quite a few of these cancers, mortality is not as high as the incidence, which means that people live in survivorship and they live with the side effects of their cancer treatment. Next, please. So sexual health care is something that is very much lacking in cancer care worldwide. So Africa really should not be singled out. So you could take my comments as really meaningful for the rest of the world as well. So cancer can be a stigmatized disease, as Professor Osir just discussed with you. And if people delay care because of the stigma, it leads to more invasive and therefore more destructive treatments. Sexual dysfunctions are stigmatized worldwide. It's a difficult topic to discuss, and that prevents sexual health care after cancer treatment. Providers, much research has been done on how much providers of oncology care have no training for these discussions, and so they don't even know that there might be in their neighborhood sexual health providers that could help them. And traditional beliefs may prevent that discussion as well, because people may not see sexual issues as a part of healthcare. But it's important, as Professor Osir again mentioned, to recognize that people's traditional beliefs need to be respected and brought into the discussion of sexual health care in cancer. Next, please. We think of cancer treatments, cancer and its treatment affecting many aspects of sexuality. So oftentimes in the research literature, people have measured the biological changes that cancer treatment produces in the human body. So there are hormonal alterations, there are body parts that are missing, maybe there's scarring, lack of sensation, pain, and fatigue. But we also know that when the body does not work well sexually, that people have strong emotions about it. They begin to worry, they begin to feel anxious or depressed. They may feel badly about their body and start thinking of themselves negatively and may not feel like engaging in sexual activity. Couples, if the patient is partnered, have difficulties. This is also shown in research discussing these issues, sometimes because they want to protect each other, sometimes because they're mad at each other, not understanding how to navigate this and not understanding the relationship between cancer and their sexual problems. And that leads to further challenges to sexuality and the sexual relationship. And as Professor Osir spoke very evocatively about, religious beliefs, cultural values, and social norms play a role as well in what can be discussed by whom and what rehabilitation would be available and acceptable. Next, please. Just a brief recap for those of you who don't work in cancer care of what cancer treatments can do to the body. So if surgery is involved, when a person suffers the removal of parts or whole genitals, this person will lose the capacity to experience sexual pleasure through those parts of the body, such as the loss of the clitoris, the penis, or through vaginal shortening. A hysterectomy and oophorectomy, part of pelvic exenteration, or losing testicles will result in a loss of fertility. Now, in surgeries in the pelvis, often nerve structures and blood flow are affected, and that leads to erectile dysfunction in men and poor vaginal lubrication in women, which can result in pain with intercourse. And then it can also lead to fecal or urinary incontinence, which can really compromise the whole operation. I mean, the sexual operation, so to speak. So it may be removal of body parts that are not necessarily genital, such as the breast, the leg, the tongue or jaw, that can lead to poor body image and inability to kiss, to feel badly about oneself. And all of these things lower desire. Next, please. Radiation can lead to neuropathy, to scarring, to atrophy of genital structures. Again, same issues for men and women. Women may have vaginal stenosis, scarring, and pain with penetration. Hormonal therapy basically leaches men and women of the biological substrate of their sexual desire and sexual performance. Men have diminished penises and erectile dysfunction, and women, again, have poor vaginal lubrication and vaginal atrophy. Chemotherapy alters the quality of the skin, particularly the mucosa in the mouth and in the genitals, can even cause blistering or insufficient saliva, so that compromises anything from kissing to the ability to enjoy any kind of sexual stimulation. Next, please. So as you saw in the earlier figure, the psychological effects can be quite massive. People lose confidence, they feel feelings of loss and grief, they worry about disfigurement and incontinence potentially, and if, as in cervical cancer, there's the involvement of HPV transmission, a potential question of other partners that can really disrupt couples' relationships. I already mentioned the difficulty in couple communication and help seeking. And as I said, cultural issues are very, very prominent. Next, please. There's not enough research literature on these issues. I'm just reporting one review study of 6 studies in which basically this is just a documentation that people experience sexual dysfunctions, diminished body image, loss of confidence. Definitely disrupts couples as well. There is some literature on the use of traditional remedies. This is not necessarily relevant to cancer per se, but these are not necessarily studies of cancer patients, but relevant to cancer as well, that people use sometimes traditional remedies. And this is something that needs to be discussed and understood in the context of providing sexual health care for cancer patients. Next, please. Okay, so let me tell you about the program. Many things in life happen by chance, and this really happened by chance. In this figure, you see Mr. Odia Uma and me and a social work professor, Karen Kaiser. We were together at an annual social work oncology conference in 2018 in Atlanta, Georgia. We were not actually formally introduced, but we were all offered an excursion to the Centers for the Disease Control. So I signed up, and next to me on the bus sits the man in the middle of this picture. And we start talking, and when he finds out that I am a sexologist who works with prostate cancer patients, he says, Daniela, you got to come to Africa because I have patients who have prostate cancer, who have so many issues, and I have female patients. Why don't you come to Africa? So I'm thinking, well, that's a big project. It costs a lot of money. How am I going to do it? So I go to the Sexual Medicine Society and ask, can you help me figure out how I can get some pharma money to support this? And they say, well, actually, we'll support it. You take a urologist with you and you go to Africa, to Kenya, and give presentations and let's see what happens. This is part of our purpose. So Mr. Uma arranged for Dr. Pastushak and myself. He's a sexual medicine urologist, to go to the Kenyan Association of Urology Surgeons annual meeting to present on prostate cancer, which we did. Thank you. And we also were invited to a cancer center in Nairobi to present both to male and female patients separately and then to the staff on basically sexual health and cancer. We didn't know what to expect, but it was hugely successful, so successful that the director of the cancer center asked us if we would come in the fall to create a one-day symposium on sexual health. And for this, the Sexual Medicine Society of North America, combined with the International Society of Sexual Medicine and the Cancer Center in Nairobi, provided some part of the funding, and support was also from the Faraja Support Center, where Mr. Odia Uma was working at the time. And we organized a one-day symposium where we had speakers who were local, as well as ourselves, and we really just tried to do an overview of sexual health in cancer with a variety of speakers, and all the moderators were local. Next, please. Here you can see the huge engagement of the audience. We had people from all disciplines. We had urologists, oncologists, radiation oncologists, gynecologists, mental health workers, nurses. Everybody came, and actually in the audience, they were kind of looking at each other and saying, oh, we practice in the same city, we should combine forces and work together. And I'm hoping that they did. But anyway, it was hugely successful. Next, please. We had 70 participants who signed up, but actually 140 showed up. And we squeezed them into the room. And as I said, we had varied presenters. We actually had a Ministry of Health official who discussed the gaps in oncology care in Kenya that included sexual health. And then we had evaluations filled out by 100 participants. And on the right, you can see that the most valued presentations were on male and female sexual dysfunctions and treatments, on sexual dysfunctions in female cancers, male and female psychosocial treatments in male and female cancers. And the participants recommended that we have more time for discussion, perhaps breakout sessions, more on female sexual health and younger people, and patient testimonials. So we definitely planned to repeat this, but then the pandemic hit. And so we didn't have a symposium until 2022, and that was a virtual symposium. At this time, all our moderators were local, and we presented on all the same issues, maybe from somewhat different perspectives. And if you can move on, please. We had participants from all over the world, actually, although most of them are from Africa, but some are from the United States, United Kingdom, and India. So altogether, almost 200 participants. And next, please. What the participants told us is, we love the talk on sexuality and culture by Joachim Osur from Kenya. They enjoyed the case, a study of the male patient diagnosed with prostate cancer, and said it is vital to share material that may be beneficial to case study and how it is applicable in real scenarios. So we took that on board, and in 2023, next please, we developed a 9-month training program where we had not only lectures, but also case presentations for which we invited the participants to submit cases, and then we had case discussion. Each session had a local presenter. An emphasis, whenever possible, was on cultural and traditional perspective. We had formal objectives outlined, and the participants filled out evaluations at the end, which included a question about how they incorporated their learning into clinical practice. And those who attended most of the sessions were given a certificate of participation. Next, please. This session was organized by a larger committee that included Dr. Miriam Utebi, who was at the time the president of the Kenyan Society for Hematology and Oncology. And we also included Dr. Jenkins, a sexual medicine neurologist from Tulane University. Many of you probably know Professor Inkarchi, who is a radiation oncologist and a sexologist combined, unusual combination and fantastic, from the Netherlands, who's also done a lot of work in Africa, so he really knew the landscape. Next, please. Here are some examples of the sessions. There are just 3 here, and you can see that all the moderators are local, excuse me, as are some of the presenters. And so the combination, I think, is really quite critical to present a credible program. Next, please. We got evaluation again from 129 participants. Of those, 114 were from Africa. And you can see on the right in the figure that the most valued presentations were explanation of the biopsychosocial approach to sexuality, sexual health assessment, managing sexual side effects, and then the psychosocial, managing the sexual side effects and the psychosocial side effects, and then also how to implement in practice. And this is what people said about how they were implementing. They said, no patient shall go home without their sexual needs addressed, one participant said. Another said, I studied an oncology consultation at Oncosexology consultation in my department and started recruiting patients. And last one said, I'm in the process of popularizing the approach first to see how it will be accepted. So you can see that everybody kind of started at a different level. Some people will go straight to creating that opportunity for their patients. Others will kind of advertise it more around their department, and others will just check out whether the culture will accept this kind of service. So that was really very helpful. And so people wanted more in-depth information about how to build their skills because they wanted to grow professionally in the field of oncosexology. Next, please. So now we are organizing a program for 2024, which will start later this spring. You see the same cast of characters who are organizing. This year, the president of Kesho is Dr. Busakala, because we want as many voices on the ground to participate as possible. Next, please. The focus will be on skills training, case discussion, and practical intervention demonstrations. We'll have 5 virtual sessions and 1 potential in-person session in Kisumu, Kenya during an annual meeting of Kesho, for which we are currently fundraising. And here are some examples of what's going to come up in these sessions: how to do a sexual health assessment, ethical and legal and cultural considerations when working with patients in Africa, how to assess and treat ED after cancer treatment, including the use of erectile aids, such as vacuum devices, intracavernosal injections and medications. Same about women, vaginal dilators, lubricants, vibrators, and so on. Psychosexual rehabilitation for the patient and the partner. And then finally, the last session will be on, again, implementation in oncology care. And because we now have guidelines for sexual health care in prostate cancer, we will discuss that in the context as well. Next, please. So take-home points from my presentation is that it's possible to develop meaningful educational programs in sexual medicine across cultures. We have found that providers are enthusiastic learners. It's important to include experts with local knowledge to make the education relevant. And partnering with local professional societies can help with dissemination efforts. And so working together, I think we can make a very meaningful contribution to improve access to sexual health care in countries that currently do not have it. Thank you very much. We have one more slide.
Oh. Go ahead.
Oh, sorry. I thought we were going to have the slide where people can sign up for this, but maybe that's coming later.
That would be great.
Yeah,
Thank you so much.
Anybody in this audience with this QR code can sign up for this training program that we will be offering later this year. Thank you.
Thank you very much, Daniela and Prof. Osur, for those insightful presentations. It takes a small step to be able to really make a difference, and that small step is what we did together with Daniela. And we've been working on really ensuring that we do more training on sexual medicine. I'm not going to talk much about it, but I would like to give this opportunity. I think there are some questions on the chat. There's one from Linda Grief. Linda is a friend of mine, I know, from South Africa. So I don't know, Professor, are you on the call? If you can put your video on, and then we can decide between you and Daniela who is going to answer this question. And I would like also to have really insightful discussions because I know there are people who might be joining from across Africa or other low and middle income countries. How do we really jumpstart sexual medicine discussion within our clinics and also in our centers, cancer centers, or even hospitals? I would like to really have a discussion on that. But before we do that, I know there's this question that was asked by Linda Grief. There are two questions that I've seen on the chat so far. I don't know if, Prof, you want to take it. How could we approach the family attitudes around sex not being a topic to be discussed in a cultural context? It's very common in Africa. For what reasons? In South Africa, some families do not allow discussions nearing death, as it invites death, and this makes preparation patients and families so hard. So the issue of sex is not brought about by the family. How do we bring that discussion into care?
Yeah, thank you. There is what I would call a socio-cultural breakdown when it comes to sexuality discussions and sexuality education. If you look at how communities functioned before disruption by what I would call, what we currently call modernity and globalization, each community had a very structured way of discussing sexuality. People are educated at a certain point about sexuality. In fact, in some communities, there were even live demonstrations on how to have sex. And when sex did not work for whatever reason, when someone had a dysfunction, communities had a way of resolving it. Now, what has happened over time is those structures have broken down, while at the same time, sexuality education has not taken off. We are struggling quite a bit with the issue of sexuality education in Africa, even having it in schools or at family level. There is a big opposition towards it. And people now think that talking sexuality is encouraging immorality or being unreligious and things like that. I think there is a great need for us to do more advocacy for the need to have the right to sexuality education, because I think we are denying people rights by denying them information and having them get capacity to be able to negotiate their sexuality. Yeah.
Can I chime in as well?
Yeah, go ahead, Daniel.
You know, so it'd be interesting to me how that could work potentially in Africa, something that we are teaching oncology providers to do in the United States, which is to make the sexual side effects of cancer treatment be a part of discussion of cancer care to begin with. So that to normalize the fact that, you know, the cancer treatment is going to have an impact on you in all kinds of ways. You'll be tired, you may have nausea, you may have these kinds of side effects, and sexual side effects are a part of it as well. To make it less sort of post hoc, to kind of afterwards to talk about it, but make it sort of head on at the beginning to say, this is just a normal counseling that we are providing at the beginning of your cancer treatment. I'm curious what, Joachim, you think of that.
Yeah, I think we need to definitely include a package of sexuality education as well as counseling and therapy as part of cancer treatment. What we know right now, many patients would like to talk about it. Most health workers do not talk about it. Of course, for many reasons, including feeling incompetent about it. And this is why training in oncosexuality becomes very important, oncosexology. We need to give capacity to our colleagues to be able to talk with ease on issues of sexuality, sometimes patients just want to be listened to. So the ability to listen to patients about their worries. Sometimes they don't want answers. They just want to be listened to, for people to know what they are going through and whether that is a normal thing when someone is going through cancer care. So I think training is very important. Having a package that includes sexual health as part of cancer care, very, very important.
Thank you very much, Professor. Estella, I'm wondering, do you have, I know you're coming from Uruguay, did you face these challenges that we are talking about, stigma around sexuality and sexual issues, and patients not really bringing them up?
Yes, thank you for bringing it up. I was just hearing Dr. Osur, and I was thinking that maybe in South America, it's not like we have all that religious background, so importantly in population, but there are other kinds of barriers or taboos that people are facing, and they struggle with them. And the most important for us, I think, is that to understand what Dr. Jakin just said. Sometimes people just don't want answers, they just want to be listened to, and we have to be friendly, and we have to have our broad vision so that we can just listen to them, give maybe some specific counseling, just maybe trying to use the implicit model or another model that makes you feel comfortable with, and give them the time and the opportunity to know that we care and that we are there for them.
Thank you very much. And I just want to reiterate, I'm looking at the chat, Zipporah Ali, who has done a lot of work in Kenya, is saying that the challenge sometimes that we face is the language that is used by the patients and partners when asking about intimacy and sex. So sometimes they don't understand, and it's very important for us as providers. What language are we using? How are we bringing them on board or starting that conversation around sex, which is something that is very, very stigmatized. It's something that is private. We don't want to talk about it. And there's a question here again, Linda Criff is saying that we are seeing that in South Africa, the oncologists do not inform patients about long-term side effects of treatment, mostly, for example, cervical cancer, and the complications of penetration that causes a lot of trauma. So there's no preparation for the patient, telling them that, we are going to put you on this brachytherapy treatment or radiotherapy treatment, and it's going to affect your sexual health. So preparing them and also preparing their partners. So we've had cases of, you finish treatment, your husband or your partner has been waiting for all this time. They're like, now you're done with the treatment, let's get back to sex. And then you realize that there's so much pain and difficulty in engaging in sex. And I think it's very important for us to begin to have this discussion. And I think the key message I'm hearing today is training for the healthcare providers, training. And there was another question I want to just go into. Could age, sex, or cultural background of a health provider be a deterrent towards discussing sensitive sexual issues during cancer diagnosis? Excellent question. I don't know who's going to take this, Daniela, and then we come to Prof.
I can take it. I can take it. So let me just tell you that when I first came to urology as a sex therapist for prostate cancer patients, several physicians came up to me and said, these men are not going to talk to you because you're a woman. And they prefer to talk to somebody of the same gender. Well, turns out that everybody talked to me. It wasn't because I was so brilliant, although I hope I was decent. It's really more that they were so relieved that somebody talked to them about a subject that nobody ever talked to them about. They had such concerns. Some even cried about the sexual problems they were having. And they had no problems talking to me. Whether I was a woman, man, or a potato, anybody who really respected their concerns was important. At the same time, I did have some conversations, for example, with African American men about some cultural differences, brought it up right at the beginning. How do you feel about talking to a white woman about sexual concerns that may, it may feel like that I will not understand what you're going through. There may be some cultural differences between us, plus I'm a European, that sort of thing. If there is that kind of a, I don't want to call it a mismatch, but if there is a kind of a difference, it's important to address it head on and have the patient have an opportunity. Well, I'd rather talk to somebody more like me, and make it legitimate and reasonable if that's available. But I think that is something that in the air, because we have such scarce resources, it's sometimes not something that we can easily offer. But we should at least say, I'm the only sexologist here. I just want you to know that, but I appreciate that it may be awkward for you to talk to somebody like me. How do you feel about it? And, I'll see what I can do about it, but it may just have to be me. At least people have an opportunity to say what it's like for them. That's been my experience. I don't know about the others. If you've had any.
Thank you. Prof, you want to add?
Yeah, I think one very important thing is it would be very important for health workers who talk about sexuality to go through values clarification. I've occasionally come across patients who say that I went to your colleagues, I talked about my sexual concerns and they just laughed at me. I've also had repeatedly people being told that it is psychological, it will go. In other words, they're brushing that topic. They don't want to talk about it. And the easiest way to close the topic is to say it is psychological. It's just in your head. It will go. You will be okay. And sometimes they are telling this to someone who is going through really serious medical issues that are affecting their sexuality, including cancer. So I think it's more of, yes, again, the need for training, but that training also should include values clarification, because a lot of people are coming from a cultural context that is a bit prohibitive of sexual discussions, and sometimes they carry this into the professional area.
Yeah, so you're really speaking to a very fundamental, basic value of training just for people to listen to the other person instead of imposing their own values.
Yeah, thank you very much, Prof. and Daniela and Estella. There's again more responses. Doctors do not talk about sexual functioning at all, not only oncologists, and it's a major problem. So again, everyone is reiterating that there's need for more training, and we've talked about the training that is going to be offered Sub-Saharan Africa. There are people who are asking Daniela that are we also going to offer similar information for USS or for training in the United States? Maybe you can answer this, something ISSM might think of.
Well, we have the Sexual Medicine Society of North America has annual conferences on these topics. We don't currently have a program. But I think this is an interesting request, and we can bring it to ISSM and to SMSNA and see what could be provided, because honestly, so far we've only thought about providing this kind of education in Africa, but it's true that it's successful enough that I think it would make sense to provide it in other parts of the world as well. And I happen to be the chair of the Oncosexology committee, so I will bring it up to our group. Thank you for the suggestion.
Thank you very much. Thank you, everyone. Wonderful. I don't know if there's any question that I've forgotten. Oh, there's more. There's more questions here. From Wood. Wood is a sex therapist. I live in the Netherlands, a country with rather advanced sexuality education. In spite of that, rather big part of physicians are scared to address sexuality, which is the key thing that we mentioned. And of course, nurses are improving in this area, so nurses could be very good opportunity to be able to talk to the patients directly. So he's mentioning that I sometimes recommend that nurses hang the messages on the waiting group so that the doctor doesn't have to address the sexuality, but the nurse can be able to do it. Something that I think can also work for us in Africa. And nurses are good communicators. They can be able to communicate with the patients and kind of like jumpstart that communication. So we have a training that is coming, Sub-Saharan Africa. Lillian, I think you can share so that people are able to take, you can take that, what is it called? Yeah, you can take a picture of the QR code will take you directly to the registration portal so that you can register and of course enjoy the training. At the end of the training, you'll get a certificate. And if you're from Kenya, I will be presenting. I will be at the Kenya Society for Hemato-Oncology conference. Thank you very much, everyone. I hand it all back to Estella. Over to you, Estella.
Thank you, everybody, for being with us. And I hope to see you soon. We have some interesting programs and webinars upcoming, and some in-person meetings in warm weather in Rio de Janeiro in September. So thank you for being with us, and thank you to the moderators, to Daniela and Dr. Osu.